Hi, my name is Brian José Luceño Quijique, and I'm going to talk about the COVID-19 pandemic and the incidence of acute myocardial infarction. Definition: acute myocardial infarction is myocardial necrosis resulting from acute obstruction of a coronary artery. Symptoms include chest discomfort with or without dyspnea, nausea, and diaphoresis. Diagnosis is by ECG and the presence or absence of serologic markers. Treatment is antiplatelet drugs, anticoagulants, nitrates, beta blockers, statins, and reperfusion therapy. For ST segment elevation, myocardial infarction, emergency reperfusion is via fibrinolytic drugs, percutaneous intervention, or occasionally coronary artery bypass graft surgery. For non-ST segment elevation (MI), reperfusion is via percutaneous intervention or coronary artery bypass graft surgery.
Acute myocardial infarction is acute closure of the coronary artery, which is related to either rupture of the plaque, leading to acute onset of thrombus formation and sudden arrest of blood supply to that area, which is defined as ST elevation myocardial infarction. You may not have chest pain in certain conditions. Majority of the time you will have chest pain, but there are certain variables like advanced age, diabetes, they may not have chest pain. Woman heart attack usually presents as an atypical symptoms, which may be a variable from the normal chest pain and can mimic different conditions. Like they can present with neck pain, epigastric pain, and different variants of the chest pain which are not typical of angina. Aortic stenosis usually presents in two forms. Either it can present because of the degenerative aortic valve disease from advanced age, or it can present from congenitally malformed aortic valve. Usually it's a tricuspid valve. If you have bicuspid valve, it's more prone to degeneration faster, and they present a little bit earlier part of their age, of their life, with aortic stenosis. So patients with mitral stenosis, they usually have underlying history of mitral stenosis, especially have underlying history of rheumatic heart disease. So more commonly seen, which has become less and less. And other conditions for mitral stenosis are very rare to happen. Mitral stenosis can be caused by, you have other patients with renal failure, patients who have left atrial myxoma, they can cause. These are the other conditions which are commonly seen. And degenerated mitral valve from advanced age, that can also cause mitral stenosis.
Applications in medicine. Among patients who present during the COVID-19 period from March 4th through April 14, 2020, the prevalence of pre-existing coronary artery disease, previous acute myocardial infarction, and percutaneous coronary intervention were lower than among those who present during the pre-COVID-19 period from January 1st through March 3rd, 2020, and among those who present from January 1st through April 15, 2019. However, demographic characteristics, hemodynamic measures like vital signs on admission, initial and peak troponin 1 values, and the burden of other examined coexisting conditions were similar in patients who present during the COVID-19 period and in those who present from January 1st through March 3rd, 2020, and in those who present from January 1st through April 15th, 2019.
So this particular webinar has really originated from this publication that was jointly published in CCI and JAC earlier this week. It was a combined effort between SCI, the ACC Interventional Council, and the American College of Emergency Physicians. And we felt that this was the right time for us to come together and issue a consensus statement on the best way to optimally treat myocardial infarction during the COVID-19 pandemic. Next slide. So I'm going to start off highlighting the three key messages from this manuscript. This is our key figure from the manuscript, and what we want as a key takeaway point is that when ST elevation patients come into the emergency room, in the current era, when we are contemplating the possibility of a COVID-19 positive or probable patient, then in those patients, there can be many etiologies of ST elevation. However, the best way to figure out how we can treat those patients expeditiously is still by going to the cath lab. For patients who are positive or probable, we do recommend consideration to a point of care ultrasound. And as long as a wall motion abnormality in the presence of classic symptoms of myocardial infarction matches the wall motion abnormality, the patient should go straight for primary PCI with appropriate PPE. In patients who are COVID possible, and that in some ways we feel should be all patients until we know otherwise, should be taken for primary PCI with appropriate PPE. When ultra rapid tests are available, they should be checked early. And I can tell you at UC San Diego, we can get an answer now in 15 minutes, so we are doing that routinely. In the absence of that or equivocal diagnoses, that's when additional imaging, which could include echo, chest x-ray, maybe a CT, to determine whether or not the patient is likely having a true infarct or are there other etiologies for the ST elevation. And that can then be a joint decision whether a cath lab is activated between the emergency department and the cath team.
Pros and cons. Data from 43,017,810 person weeks from January 1st through April 14, 2020 were evaluated. The weekly rates of hospitalization from acute myocardial infarction decreased by up to 48% during the COVID-19 period. From January 1st through March 3rd, 2020, a total of 1,051 hospitalization events occurred. And from April 8th through April 14, 2020, a total of 61 hospitalization events occurred. Decreases were similar among patients with NSTEMI and those with STEMI. The decrease seen in the comparison of the COVID-19 period with the pre-COVID-19 period in 2020 was similar to the decrease seen in the comparison of the COVID-19 period in 2020 with the same weekly period in 2019.
Incidence of STEMI patients among the ones who have been infected with the virus. Actually, when the patients are in the common ward, they are mainly non-invasively ventilated, and the EKG monitoring is really very low. And these patients usually are much more affected by their respiratory symptoms than by any other kind of symptoms. So these patients so far have not attracted the attention of cardiologists so much. When they are in the intensive care units, mechanically ventilated, if the situation is going worse and worse and the severe respiratory failure is becoming more and more evident, the development of a multi-organ failure is the natural consequence. So they could have also some changes in the EKG, they have some alterations of troponin, but so far we haven't had acute coronary syndromes in these patients, or at least they have not been brought to our attention. Probably even the heart involvement is much more related to the virus. So it's difficult to say what is the mortality of infected cardiovascular disease patients, but for sure cardiovascular disease patients have a worse outcome. The mortality is much higher in cardiovascular disease patients than in patients without any cardiovascular disease. And unfortunately, the mortality is even higher in cardiovascular disease patients compared with hypertensive patients who have a higher mortality compared with patients without any risk factors. The grading is patients with no risk factors, lower mortality, patients with some risk factors, higher mortality, and patients with cardiovascular disease, the highest mortality.
Issue applied in Ecuador. There is a case study that says in Ecuador there were 18 patients with ST segment elevation myocardial infarction last month, and the average age was 63 years.
Another question is related to whether there are other cardiovascular disease that could be an emergency and who develop while the patients are affected by the COVID-19. Actually, we don't have any clue about myocarditis. Still, I point out that this is an infectious disease mainly characterized by an interstitial pneumonia, and what we see in terms of alterations of troponin is really much more related to the ischemic situation or relatively ischemic situation secondary to the hypoxia for the respiratory failure. So it's difficult to see patients really developing a situation that is much more related to a myocarditis than to the respiratory failure. While we don't see arrhythmias or conduction disturbances more than in the common situations, and this could be considered an indirect sign of myocarditis. So again, we don't have indirect signs of myocarditis in these patients. Much more difficult to say whether patients with a COVID infection develop an acute heart failure or a cardiogenic shock that is primarily related to their cardiovascular disease. Actually, in the very advanced stage of the infectious disease, the heart failure is almost always associated with respiratory failure, and it's really difficult to interpret the CT scan or the chest röntgenogram where the images are quite similar, no differences between the pneumonia and the acute heart failure.
Conclusion. In a large diverse community setting in California, the incidence of hospitalization for acute myocardial infarction declined after March 4, 2020 during the COVID-19 pandemic, more than would be expected on the basis of typical seasonal variation alone. Similar findings have been noted in northern Italy.
Throughout the state, California's Governor Gavin Newsom is allowing flower and bookstores and a number of parks and golf clubs to reopen, but nothing is going completely back to normal yet. For businesses, orders must be made online or by phone and picked up on the curb. Still, though, welcomed news.
Last 4 or 5 weeks, I lose money because I can't sell my flowers. We can't stop the flowers. You know what I mean? The flower is coming, you need cutting out.
This Los Angeles farmers market is opened with restrictions. For starters, no one can cross this yellow tape.
No one can touch the produce unless they're buying it. We're handling it for self, and for a team, we have like someone to handle the produce, and I handle the money, and everybody just needs to keep the 6 feet distance.
There are fewer people here. That is one of the reasons some stores that now could be open are staying closed.
The big issue is even if retailers open, are people ready to go shopping? And I think that the jury's still out on that. We just don't know.
Ksenia Bay's nail salon has been closed since mid-March. She can pay rent later and received government financial help, but Ksenia says it won't be enough. When she can reopen in June, mandatory safety restrictions could kill off her business.
We are designed to serve 14 clients at a time, but supposedly when we're allowed to reopen, we'll have to cut that number in half, and that's unprofitable for us. We have 5 pedicure chairs that have less than 6 feet between them, so I can only use 3. With a larger rent I need to pay, the salon just won't survive.
But for the critics, Governor Newsom points out where the coronavirus outbreak in his state started.
This whole thing started in the state of California, the first community spread in a nail salon.
State authorities are trying to take advantage of this unusual time to do renovation work. The famous Santa Monica Pier that is normally swarmed with people is going through some long-needed repairs. Frangilina Bagdasaran in Los Angeles, NRI's VOA News.
Thank you.